have you guys take some blood pressures. And so we're going to talk about a few things along the blood pressure. So for the next 15 minutes, I want you to try to take respiration, especially if there's somebody around you. Take your left and right pulse yourself and your carotid, see how they compare. Take it if somebody's around you, you can get them to let you do that. Then whether it's you or somebody around you or both, then do something slightly strenuous. Get up and walk up and down around the room a little bit. Do a few 2 or 3 jumping jacks, and then take your pulse again, and then take it in about 5 minutes. Okay, and that's a good one. Unless Edie, she decides to make you go right along with it. So that's what my daughter. I would not take my granddaughter on in a plank. The little kid can sit there and do a plank for like 5 minutes. Actually, the other day, that's what they were doing in Krav Maga. Is we had to practice disarming somebody with a gun, but they made us do push-ups, a lot of push-ups to fatigue our arms, so that we would have to deal with, if our arms are fatigued. And it's a big difference between when you do that. So, all right. So we'll come back. We'll come back in, it's roughly 20 minutes. We'll make it on the hour. And when we come back, we will then talk a little bit about some of the issues. Then we're going to talk about taking blood pressures. Okay. All right. I'm going to mute this side, and we be back ready to go on the hour exactly. All right, guys, we're back, and I hope you were able to get to be able to measure your pulse. I know it seems pretty simple. It's one of these things, some of these things that we're doing, respiration and pulse, it seems very, very simple, but I guarantee you it's the more practice you get, the better off that you are, and it'll start becoming second nature. And again, these seem like relatively easy, but it's just getting used to it. If you can take somebody else's pulse a little later on this year, or a little later on this year, a little later on this week, or later on, it really will help you. It's one of those things which I would just, when you can, try to practice as much as you can, so it becomes second nature. One of the things that you might do is you might, try to, over the next week, find people that that have different wrist sizes, for example. That's one of the things. People with different body sizes and shapes is just monitor their respiration. Just, I don't want to hear of any of y'all sort of getting arrested for being creepy while you're sitting in a bar or something and you're trying to use somebody. Just say, well, honestly, I wasn't staring at that person. I was just taking their respiration. So try to do that. But anyway, so that's one of the things, and you'll be taking some more of those next time we meet. I think Allison is going to have you do some of those in addition to some other measurements. We're going to, so just to give you a feel for what will happen is the next time we meet, Allison will be meeting with you guys on Saturday. She's going to talk about several other the physical assessment issues, and then I'm going to meet back with you guys on Sunday. We're going to go over some things there. So go over and introduce you with a little bit new information there. All right. So let's move to the next vital. And this one truly does take some time to get used to taking a blood pressure. So blood pressure is going to be a very important parameter that we will take. Way that we do blood pressure is it's an indirect measurement. A direct measurement would actually require us to stick a needle into your arteries. And obviously, there would be a major concern with that because of is that there would be the issue of introducing infection. But the biggest concern would be sticking a blood vessel into an artery has a lot of problems associated with it, with bleeding and so forth. So the indirect measurement of blood pressure is what is frequently used. And what's going to happen is we're going to place, I'm going to go to a previous slide here showing the vascular anatomy. So typically when we're going to take blood pressure, we're going to put the cuff. Let's see if this will let me do this. So we're typically going to be putting a cuff on the upper arm. So the cuff is going to be here. And so what we're literally going to do is when we can also take a blood pressure down here in the leg. We can take it by putting a cuff over the leg. We don't do that frequently. There are a few conditions which we would do that to measure. But what I want you to do is when you practice this, you will find that one arm will be better than the other one from a standpoint of what you find is easier to do. And so with this, the other thing, and here's while I've got it here, this is the antecubital fossa. So it's the inside of your elbow, and you can see what they've drawn is they've actually drawn, which is like the biceps tendon here. And you can see where the cuff is. And what we're going to do is we're going to place our stethoscope there. Now, did it jump? Yeah. So the cuff is going to be placed over the brachial artery. And that is, and then what we're going to do is here's what we're looking for. Let me give you the basis of it. We covered it a little bit when we talked about hypertension. So you guys remember the term Korsakoff sounds, okay? So let me get here to everyone, and we use the term Korsakoff sounds are basically what Korsakoff sounds are is it's actually the sounds created by turbulence. Okay, so with turbulence, what happens when blood is flowing in a laminar mechanism, we have very little turbulence. But when we constrict the arteries or we change the diameter of the arteries, or we put branches there, then it creates turbulence. Okay, and turbulence is is what we're listening for when we hear the blood pressure, or when we're listening for blood pressure. So here's what we're doing. Here's the basis of it. Let's talk about it. All right. So when we put the cuff on and we inflate it, literally what we're doing is we are squeezing on the arm and we're squeezing the tissues down with the cuff so that we are reducing, we're actually shutting down the brachial artery. We're basically pressing it closed. And that's why we hear the disappearance of sound. So when we're listening to to our stethoscopes, we will basically inflate the cuff until the artery is completely collapsed, so it's shut down. And what we're listening for is that when we lose the sound, then that is the systolic pressure. What we've done is we have generated enough pressure that is slightly above the pressure of the blood pushing out on the blood vessel, so that has collapsed it. So that is our systolic blood pressure. That gives us, when we lose the sound, that's systolic. So now as we release the cuff, then the first sound that we hear is basically when we've reestablished some blood flow in through the artery. So what we're doing is the systolic pressure is we are squeezing the blood vessel. We're getting, when we lose sound, then we've got the artery completely closed, which means we've generated pressure slightly higher than what's in the blood vessel, and that's pushed it shut. So that is, and that's why you don't want to leave the cup on for a long time, is so what we're doing is we're closing it. I twisted that around just a little bit. So race your memory banks. So we shut it completely down when we puff it up. Okay. So when we release the cuff, the first sound we hear is where that we have just picked up there's just enough pressure to push blood through there. That's the systolic pressure. As we continue to release the pressure, we will lose, when the sound goes completely away, what's happened is the blood vessel is completely open. And what that tells us is that that's the pressure at which the blood vessel is open, and that's our diastolic pressure. So we're going to pump it up, and then when we start releasing it, the first sound is where we've got just a little bit of blood flow going through, and that's where that we are just below the pressure in the artery. And that gives us, as the blood starts seeping through, we get some chaotic blood flow. That gives us these Korsakoff sounds. That's our systolic pressure. As we continue to release the cuff, then the blood vessel opens up. And once the blood vessels completely open up, then we have reduced the turbulence till the point we can't hear it. Okay. So we're going to use the brachial, and that's true for whichever artery you use, whether the brachial or the femoral. Now, if possible, when we have you practice blood pressure cuffs in just a minute, or taking blood pressure in just a minute, what I want would like for you to do, and it's easier if you can do it on someone else, but you should be able to take your own. Sometimes taking your own blood pressure and adjusting the cuff, it takes a little bit of practice there, but if you can practice on somebody, take the blood pressure in the left and right arm. Okay. Now let's go to the next slide. So here's the cuff placed on here, and notice you have, most of these cuffs will have a little indication. You can see here it says artery. So you try to place that over the artery, and the biceps tendon is right here. So it should be right there in the middle there. And then what we're going to do is we're going to inflate the cuff. And so, like I said, when we inflate the cuff all the way up, as we release the cuff, and here's where I find most people need a little bit of help, is sometimes getting used to, some people may have some finger strength issues. So when you start to release the little knurled knob, it's getting used to slowly releasing it, and again, just slowly releasing it and holding it there. So if we take the blood pressure in the left arm and right arm, they should be fairly close. They should be within 10 to 15 millimeters of each other, okay? The other thing we can see is sometimes people, when they're taking the blood pressure, they will put their fingers on the radial pulse. So what they're feeling for is they're actually feeling for, so they're listening for the sounds, and they're feeling for when the pulse is reestablished, what's going to happen is you will feel the pulse come back. When you plate the cuff completely up and it occludes the artery, you should feel no pulse. But then as you release it, you will feel when it returns. So some people like to do the oscillation of the radial pulse, so they can feel it when it shuts down. They can feel it when it reestablishes. And some people will look at the sphygmometer and be able to do that. Now, if you're using an electronic cuff, again, there are the ones that are completely electronic. You can use that in your office, but you really should have one where you can listen. You really should have the manual ones. It's fine if you get the ones that inflate the cuffs up, but you should be taking it manually, because as I think I told you guys last time, is electronic ones are good, but if the batteries go out, or sometimes some of there's a question sometimes, are they calibrated properly, especially if they've been tossed around a lot. Something can happen there. And I just find that the old-fashioned, the cuff with the manual sphygmometer on it, you could fold it up, put it in your drawer, desk drawer, and you can have it, and it's really not a problem. Now, although this says JNC 7, we are now at JNC 8, but basically the blood pressures are still the same. So remember, when we're looking at blood pressure, is that we classify it based upon what is the highest pressure. So someone that's normal, their blood pressure their systolic pressure would be below 120 and their diastolic would be below 80. Okay. Somebody that's pre-hypertensive, their blood pressure is 120 to 139 systolic, or 80 to 89 diastolic. So if we have somebody whose blood pressure is, say, for example, 119 over 90, that person's blood pressure would actually be a stage 1. So we take the highest blood pressure to classify them. Stage 1, their systolic is 140 to 159, or diastolic is 90 to 99. Stage 2, their systolic is greater than 160, or their diastolic is greater than or equal to 100. Now, there are people sometimes, there's a term which we mentioned when I taught you pathophysiology or clinical medicine. Elderly patients, you may sometimes have an elderly patient that has literally a really high systolic pressure, say maybe over 160, or even sometimes even in the above 140, around 150, 160, and their diastolic pressure is normal. Some people will sometimes refer to that as isolated systolic hypertension, meaning their diastolic is normal, completely normal. It's just their systolic pressure is elevated. And that is one of the things that can occur from a standpoint of that producing an effect there. So that's just another term that's used. But I will tell you that on your test that you will have a question about if a patient's blood pressure is this, that patient would be, and then we would have that. A couple of things when you take a break, or actually I don't think we'll stop. I may give you a short break where you can try blood pressures, but if nothing else, if we take a short break, I want you to do a couple of things. I want you to put your stethoscope on when we take a break, and it's not going to take a long break to try to take blood pressures, but I do want you tonight to try to, or this evening or tomorrow or sometime this week, to practice doing some blood pressures. But here's what I want you to do at our next break, which we will take, in half an hour or so, is I want you to put the stethoscope on, and I want you to take the stethoscope, and I want you to basically move the stethoscope across your clothing and listen to it. I want you to pull the stethoscope and move it across the hairs on your arm to hear those sounds. I want you to rub the tubing of the stethoscope against clothing so you can see that those sounds will come up there. But what we have to worry about with regard to blood pressure, where the errors can occur, is sometimes what you're doing is you come in and basically they'll put the blood pressure over clothing, or they'll roll up a sleeve. And so sometimes that can give an artificially elevated blood pressure. It works best if you can, put it directly on the arm, or if you can, if worst case scenario, if you've got a thin, like a t-shirt on and they put it over the t-shirt, that's fine. But better, the more accurate reading is going to be there, but on the arm directly. But really where you get a concern, if someone is layered, they have a sweater, a shirt on underneath the sweater, maybe a t-shirt, and you put that cuff over that, that basically you've got all that padding there underneath it. We've mentioned that any activity prior to measurement can produce an effect, can elevate your blood pressure. Alcohol, caffeine, tobacco, if they smoke right before coming in. Another thing is this time of year, in particular, sympathomimetics. This would be somebody taking allergy medications. A lot of the allergy medications or decongestants can raise heart rate and raise blood pressure. And we also have condition of white coat hypertension, where basically that people get nervous in the doctor's office, and so it's called white coat hypertension because when people see the white coat of a doctor, is basically they get concerned, and that they get anxious, and it elevates their blood pressure. Sometimes it's another person can take their blood pressure, but again, we're going to make these readings not on a single blood pressure. A diagnosis of hypertension is not made on a single measurement, or a measurement, 2 or 3 measurements on the same occasion. So if your blood pressure is elevated, or your patient's blood pressure is elevated, what we're going to want to do is primarily have them come back and let us take another blood pressure a little bit later on, maybe a few days later or a week later. Now, another condition which your patients may have, either because it's drug-induced or sometimes it just may be them, is orthostatic hypotension. And a lot of the drugs that you will prescribe can cause orthostatic hypotension, okay? So how do we diagnose it if we're going to do it? So what we do, and the way we diagnose this, is we have the patient lay down. So we have them supine, and we take their blood pressure. And then what we do is we have them stand up for 2 minutes, and we take their blood pressure. Typically, we're going to see that the systolic blood pressure should not vary more than about 20 millimeters of mercury with them laying down and them standing up. We will see the heart rate change, because the heart rate is trying to adjust their blood pressure and shift things around. That's a compensatory response. But what we start seeing is if the systolic blood pressure varies more than 20 millimeters of mercury, what that means is when they're changing position is their body is not compensating. So the greater the change, the more likely it would be clinically relevant. So it is not uncommon for a patient, when they're first starting certain medications, an antidepressant, some of the antipsychotics, that we may tell them, especially if they're an elderly person, we may tell them to take it easy when they're first getting up. It take them a little time to get adjusted to it. People on blood pressure medication, the same thing. Water pills, diuretics can do it. So what we tell them is when we first put them on it, that they may be a little dizzy. The older they are, or if they have other complications that may affect their blood pressure, we're going to be a little bit more cautious. But what we typically do when we either put them on one of these drugs that can cause orthostatic hypertension, or we change the dose of one of these drugs, we tell them you may get a little dizzy, you may feel a little bit like you're going to faint. So when you get up in the morning, just take a little bit longer. Instead of hopping out of bed, then what we need you to do is maybe raise up part of the way and sit there for a minute, let your blood pressure drop before you stand up. But if we need to check that out, then we can do this. So have the patient lay down, take their blood pressure. Typically, we leave the cuff on there, and then we have them stand up. And after about 2 minutes after standing up, basically we take their blood pressure. And if it's under 20 millimeters of mercury between the two readings, not really worried about it. They still may be a little dizzy, but we still are going to be a little bit more cautious with regard to that. Now, the other measurement, which you may decide to do, not everybody, these pulse oximeters have dropped down in price quite a bit, and you can hook them up. Typically, the pulse oximetry is going to be, we're going to take it on the finger. This is one means of measuring really your gas exchange, how much oxygen is in the blood, if you will, or the red blood cell carrying capacity. And like I said, this has now become like the fifth vital sign. Not everybody measures it, but more people are measuring it. And typically, a person normal, we should see their pulse oximetry in the upper 90s, 90 percentages. 95, 98, probably around 98. People with starting having cardiopulmonary disorders, we may see it drop down. It's in the 90s, but it's the lower 90s. And when we start going below 90, we start getting concerned that they are having difficulty giving, that their blood is not being oxygenated. Smokers will be typically in the low 90s to the upper 80s. And so people do use this. Sometimes it's not one that I would see that you necessarily would have to have. I definitely think you should be able to monitor pulse and blood pressure for sure, and respiration. Those three for sure. Temperature is there, and then this one is a potential. The pulse oximetry, as I said, typically the ones that we see is placed on the finger, and the ones that are you can get some that place on the earlobe. The earlobe is the other place that you can use to measure it. All right, so let's do this because we got one more slide set. And what I'm going to do is, last week we waited till the end. We waited till after class and said take the post test. Really, that's really not fair to you guys, because we should really give you the post test as part of the class. So what we're going to do is, let's take 6 minutes. I'm going to put a new slide deck on. You guys take a stretch, and if you can listen to your stethoscope, do that. But I'm going to put the third slide deck on, and then we are going to pick back up. And this third slide deck will move through fairly quickly because it's some areas we've touched on already. And what we'll shoot for is to give you some time. What I will do is finish up no later than, say, let's see, class is over at 4, no later than 3:30, and we may make the test where that you can have like 30 minutes to take the post test, I think is what we're going to do. So you guys take about 5 minutes since I've run my mouth. Come back. Well, let's come back at 5:35. So get a stretch, listen to your stethoscope. I say 5:35, come back at 35 after the hour. And I'm going to put the other slide deck up on, and we'll go from there. Okay. What's the big old boy doing? Okay, guys. So we're on the last portion of this class here. You guys realize that now this is by the end of the day, you're 2/3 of the way through another course to check off. That's pretty impressive. So let's talk about medical records. And again, some of this stuff we're just going to touch on, and some of it I'm going to spend a little bit more time on. One of the things, this is an old mantra that stands there, and I will tell you that everybody says this in legal situations. This is always an issue that comes up. You know, basically, did the person will say, well, you know, did you know this? No, but I know that. I just didn't chart it. So this old aspect of it is this old mantra that's been up for such a long time basically is, if it's not charted, it didn't happen. It's important that the charts be kept. And from looking at medical records for several years, even decades in a way, it's amazing to me that there's not more errors than there are. But it's important that it's charted, because what happens here is other people may be relying on your charts. You may be relying on other people's charts. So although, you know, typically I hear a lot of people, I know I did it because I do this is what I do for all my patients. We hear this with nurses. We hear this for physicians. Did you counsel this patient? Did you, did this come up or whatever? And basically everybody says the same thing, but you go to the charts and you can't find it. So it's important that the charts be charted and it's as correct as possible. If there's errors, the video I gave you guys last night, what I thought was very important was the nursing talking about how to make notes on charts and things like that. Because if there is an issue and there has been an error or something like that, you know, we were taught in basic chemistry and biology lab is you don't erase or anything, you mark through it, strike through it single, so you can look back, and that can sometimes help help you remember what's going on or what the person may have thought or whatever. And a lot of times we had to put as the reason for the change, you know, but when we look through the charts, and again, the thing is that the chart should be arranged in this way. Some pieces of these charts may or may not be present depending on the particular patient, the circumstances. But for every patient, we should have a basic history and physical. Okay, this pretty much gets with what we were talking about earlier today. This should document the patient's medical history and findings from the physical examination. So that should be in your charts. Typically, this history and physical is going to be the first document that's generated when the patient presents for care. We talked about all of those different questions that we need to ask when it's coming up there. A lot of times this is going to be generated at the new patient visit. Many times we have this history and physical is like we talked about before, is there's a, each office has a typically standard information where you get. If it goes to a consultation, then the consultation should have this information in it also. All right, let's jump to a question real quick. So thinking back from what we had before the break, you got a person's blood pressure is 110/60. Is he pre-hypertensive, stage 1, stage 2, or normal? And most of you got that, which is normal. One of the things, let me just mention about blood pressures. It's not uncommon for women to be, we see a lot of women patients, more so than men, but we may see some men, but their pressure may be 90/60. And sometimes they're more susceptible to syncope because their blood pressure is a little bit low. But the correct answer of this is normal, because both the systolic and the diastolic pressures are below, are in the normal range. So good job, guys. All right. Also, as we go through this section, I'm going to give you some standard abbreviations. I think most of you have probably seen them, but just in case, it's one of those things that you need to be aware of. So we start off with history, often abbreviated as HX. This documents the subjective information. This comes typically from the patient's personal statement, and it can include things such as past injuries, illnesses, operations, habits, and so forth. Typically, the history starts with the chief complaint, which is abbreviated CC. This is why the patient is here. This is the thing that is utmost important to the patient. This is the thing that basically the patient comes to you because this is what's typically bothering them the most, or someone has made them come to you because it's there. Typically, it's a very brief statement, and sometimes it's hard to figure out. So it may be, could be as simple as, I'm here because my stomach's hurt. Anything that the patient, as they describe it in their own words, what we like to do is to put quotations there, because that is how the patient is perceiving it, and that helps us know that it's not us paraphrasing or somebody else paraphrasing. This is what the patient has said. Some things that you guys will get that can be sometimes helpful for you. So, for example, I've seen depressed patients come in, and you ask them what's wrong, and they'll say something like, "I've got me on my mind." They may describe, I have racing thoughts and things like that. So anything that you're going to put in there that is a direct quote from the patient is basically, that means this is what the patient has said. And it gives you an idea really of what seems to be, in the patient's perspective, the most important thing. Typically, we may have a person coming in and we will say something like, a 64-year-old white male presents today at the clinic or presents today at the office, C/O, complaining of. So C/O stands for complains of, and it could be of having difficulty sleeping, quote, can't stay, falls asleep but can't stay asleep, end quote. Now, in this history, we're going to have several components that we're going to try to get. Some of this the patient may give us when they fill out the paperwork for the visit. Some of it may be garnered from our questions and making sure that we ask the right questions. So the present illness is PI, or the history of the present illness is HPI. So this basically is giving us details of the complaint. So we're looking at, this is what's currently happening, and it's telling us, for example, has been having difficulty falling asleep for the last 2 weeks. So that's giving me the history of this present illness. I'm coming in because I'm not sleeping well. Okay, how long has this been going on? For the past 2 weeks, I've not been able to fall asleep, or I've been able to fall asleep but haven't been able to stay asleep. I keep waking up. The symptoms are obviously I'm not sleeping. Could be I'm very fatigued in the morning, but there may be some other things. For example, I may say my stomach's hurting, and I think it's because I'm getting a little anxious because I can't sleep, or I'm getting nervous about the fact that that when I get to work or I get to school, I'm falling asleep in my classes. And so those are sort of the things that we get. It's basically this is telling us, why we're here, what our chief complaint, sort of giving us the other things about our chief complaint that we can use. Symptoms is sometimes abbreviated as SX, S_x. And we also then, we will want to get some past history. Again, much of this may have been garnered from what we have gotten from the patient's paperwork that the patient has filled out, typically in the waiting room. Some of this past history may be pertinent. Some of this past history may be missing. Excuse me. So the past history is PH. The past medical history is PMH. Both of those are used. So basically, past illnesses, starting with childhood. One of the things that may happen is somebody may not remember all the illnesses they had as childhood. You will get the occasional patient that can tell you pretty much every time they had a sore throat, every time they skinned their knee, every little thing, and they may put that all down in the records. Surgeries, injuries, physical defects that they may have had, history of medications. Obviously, I could not tell you what specific medications that I had when I was a kid. If you were to ask me, did I have penicillin? I can tell you, yeah, I had penicillin, but I couldn't tell you if it was ampicillin, amoxicillin, or whatever it was. The allergies and the medications that they do remember are good, which means they probably can take those medications if you happen to need them to use them. I need to use them. The allergies is very important, and then when we get the allergies, as what we talked about this morning, is we want to get more information about those allergies. So we haven't quite covered this yet, but let's just see what you know. The chief complaint should contain only objective information. True or false? Okay, that's false. One of the things that we need to know, and this is something that is coming up now, is we have objective and subjective information. A lot of people like to put a lot more weight on objective information because it's something that can be measured and it's more finite. Some people think it sometimes is more reliable. So we're going to come into some of these things in just a moment and talk about subjective or objective. But subjective information is going to be, things that can't be measured, and it's going to be just as important, especially in the diseases that you guys will be dealing with. So continuing on with the history, the past medical history, a couple of abbreviations that you should be aware of. UCHD, that stands for usual childhood diseases, measles, mumps, chickenpox, things like that. These two, I'm getting a pen pulled up here. These are going to be very important, okay? Whether they have allergies. All right. So if we ask them, do you have any allergies? They may have an allergy that we just haven't discovered yet. But if we have NKA, that means that there's no known allergies. They can't remember any allergies. Nobody can, nobody's told them about it. And sometimes NKA can stand for no known allergies, which includes drug allergies. But one of the things that you might want to do is verify. Somebody may think that an allergy is, am I allergic to pollen, things like that. But if NKA could include drug allergies, but it could not include drug allergies. So it's always good to find out if they have any known drug allergies. Anytime you're starting to prescribe, one of the questions that you would want to ask is like, do you have any drug allergies? And then you might want to say, are you allergic to the drug that you're starting to prescribe? And if they, or have you ever had this drug, if you think they've done that. But the allergies are one of the things that and especially drug allergies, is something that we want to be aware of. The family history, we're really interested primarily in the immediate history, the immediate family members. One of the questions we gave our pharmacy students was, the patient comes in, we had a 29-year-old female, she's married, she doesn't have an allergy to penicillins, but her father-in-law is very allergic to penicillins, so she can't take penicillins. Well, the problem with that is obviously she's not directly related, or we hope she's not directly related to her father-in-law. But the family members is basically who we're really looking for is mother, father, and siblings. But if we can get grandparents, that's good too. So we definitely want to know the immediate family members, the state of their health, and whether there's any disease or condition which may be directly related to them. That's, again, when we ask family history, we typically want definitely father and mother and any of your siblings. But we also, if we can get it, grandparents is very good too, is even better. So this, I've actually answered it. Should the family history include information about the health of the in-laws? Yes or no? A or B? All right. Generally, I would say I would agree with you, and the correct answer as I asked this question was no. But there could be something that may be important. So, for example, somebody comes in with an infection, and I find out that their in-laws, that they have been living with their in-laws, and their in-laws have had all their in-laws have had the flu. So, Najib, you actually got the best one. It sort of depends. One of the things that you guys might be, for example, living the in-laws, or what's going on with in-laws could be causing some of the anxiety, could be causing, maybe contributing to the depression or something like that. So in generally, the family history, we don't routinely say about in-laws, but it is a depend. It's one of those questions that it really depends on possibly who your in-laws are, and possibly what your in-laws may be having or may have an issue there. So there are times when that family, with the in-laws, the family history may be important. The social history sometimes is can be a little bit ambiguous with what the patients give you. Sometimes most people may not be, if we're dealing with an orthopedist, and the orthopedist is, we've got somebody that's coming in with a strained or sprained ankle or pulled muscle or something like that, then the social history as far as the recreational interest and hobbies may be particularly important. If we come in, somebody's reacting to something, and we may find out that one of their hobbies may be that is exposing them to some sort of chemical or something like that, that's there. But typically under social history, what we definitely would like to know, and again, it can vary quite a bit, is use of tobacco, alcohol, or drugs. And you will find, if you haven't already, that in the same patient, from different perspectives, you can get a wide range of the. I've had a situation where that the spouse says that no, that there's they stopped drinking years ago, and the patient himself says, I'm drinking, a 6-pack a day at work. So we see types of things. Sometimes the drug situation, people tend to give you, for example, if it's marijuana, we would probably see individuals say, we see more people that would tell us that they smoke marijuana occasionally than we would in the past. But other drugs, sometimes we have people who'll tell us, well, yeah, I do coke, or I do meth, or I do something like that. Sometimes they didn't. So, Angela, so if I ask you that question before, I would have taken, hopefully I wouldn't have asked you that question that's ambiguous, but if I'd asked it like it would, the answer would have been probably B. That's the most standard thing. So it would be a poorly worded question on the test. I would actually, if I was going to ask it on I asked that to generate discussion, but if I ask it on an exam, I would probably put, change the answers around so that it would have something there. I wouldn't make that on like a true false type question. Okay. Occupational history, again, is if there are work habits the individual has that may involve health risk, and that could also include, could work habits contribute to anxiety, depression, or something like that. And next week, or next time we meet, we're going to go through an ROS, or review of systems. In a little bit, we're going to go through all the different systems sort of going down there. But review of systems, or ROS, is one of the things that I like to look at quite a bit. This basically is a complete review of the functions of all the body systems. Okay, these can give us a good assessment of a lot of things going on, and that's why I like to see the ROS. And sometimes though, you will find the ROS is they will only hit, especially going in through the ER, they may only hit key points, or what they think is the most pertinent points, and several things they may not assess. And so I've seen that, but I would, what you really want is, this gives you an overview, and we're going to go into much more detail about this when I see you guys the following week. So to hit, and I'll give you some things as we're doing these review of systems. For example, during the physical exam, so the review of systems, we're going to go in GI, we're going to go the head, neck, we're going to go the eyes, nose, and ears. And so we're going to go down that, and we'll see that. But in doing the physical exam, you're going to be filling in these review of systems to an extent. So the physical exam initially is going to give us more of primarily we're going to get a lot of the objective information. Okay. So there's some abbreviations I want you to be aware of, and I've got these highlighted because they are going to be used, and you do need them. So HEENT, that stands for head, eyes, ears, nose, and throat. So what you might see under the review of systems under the physical exam would be HHENT. And so it would make any notation of abnormalities and sometimes of things with normal. Under HEENT, it might say that nose is bleeding. It might say that discharge coming from ears. PERLA is the abbreviation for pupils are equal, round, and reactive to light and accommodation. So typically what they've looked at the pupils, for example, if we had, we'll go through this next time I meet with you. If one pupil is dilated and the other isn't, it could be a stroke. If the pupils are not reactive to light, we'll talk about that a little bit more. A lot of times they will use under physical exam an abbreviation called NAD, which means no acute distress. It means basically the person's not writhing around. The person is sitting there being somewhat degree of calm, but it's not doubled over in pain and things like that. Sometimes under the review of systems, they'll just put WNL, which stands for within normal limits, which basically means that when I looked at each one of these systems, they look normal. May not mean they are necessarily normal. It means that just looking at them or what we're observing now is. Now, if we were to go and do a specific lab test or something like that, we might find that there are some abnormalities there. But just the overall appraisal from a physical exam, WNL means that they're pretty much look what we would expect them to see. Then the other abbreviations you use during the physical exam, and I think many of you have used them, is IMP, is what your initial impression is. That is your first concept or your first thing that basically comes to mind. And it may be initial impression. Impression is this. Then you may have what is called RO, which is down to your rule out. So you might say this person looks like they have I'm trying to think. It may look like that they have GERD, but rule out cardiac problems. Okay. DX, abbreviation for diagnosis. And then A is assessment, just like with a SOAP note. And then you're going to come up with a differential diagnosis. So when you get this, you get an initial impression. But just like we did the thing with the chest pain. So with the chest pain, your initial impression, they present with that. Your initial impression may be angina. Maybe you have an obese person and they were out working in their yard and start developing chest pains. Your initial impression would be, maybe angina. Rule out things would be GERD, ulcer, other things, because you may not know at the point when they first presented, you don't know that right before they went out and worked in their yard that they didn't eat a huge meal. And maybe that's what occurred. Or they were laying down after eating a huge meal. And when they got up to go out in their yard is that you had some gastroesophageal reflux. That rule out is going to involve doing a number of tests and procedures to try to determine each of the suspect condition. So, for example, with the person with the cardiac issue, what we might want to do begin with is do an EKG and enzymes to see if those are changed. So when we're ruling out and doing this differential diagnosis, what we literally are doing is trying to get the evidence by, remember that when you're doing a diagnosis, we can there are some things which when it occurs, we can diagnose it directly from that. There are other things that we get to a diagnosis by ruling out everything else. And those ruling outs also tend to not only rule out, but they also help us verify the diagnosis that we have or that we've come up with. So here's a good example and a question. Here's another one of our questions. A patient presents, their chief complaint is fatigue. What would you include in the differential diagnosis? So just, a couple of things just put in for your messages are in there. Okay, number one is insomnia. Could be cancer, could be anemia, could be depression. What else? Anything else that you guys can come up with? Could be cardiac, could be a hormone imbalance, could be diet, malnutrition, heart lung problems, liver dysfunction, so hypothyroidism. So you can see from just this look here, from what you guys just popped up, if somebody comes in with fatigue, then the point is there may be some other things, like, for example, if the guy's eyes were, really red and it looked like he hadn't slept for ages, then one of the things might be, I'm going to think with sleep. One of the things may be, it could be some other disease. So when I run a lab panel, that lab panel could tell me whether he's anemic. It would tell me if there's some liver problems, things like that. So there can be a number of these things that are going on, and we have to do that. So after we have examined it and we have assessed the patient, we looked at the subjective, the objective things, and we have we've done an assessment. Then we're going to come up with a plan. You guys are familiar with the SOAP note. So this is the provider's recommendation, or his recommendation, he or she's disposition of what needs to be done with this patient. Should be some strategies designed to treat the patient. So that includes making sure the patient has and understands what they need to do. It will include any orders for meds, any additional diagnostic tests, any other therapeutic modalities that should be included in the plan. So again, we take the subjective, the objective, we do the assessment by looking at that, maybe getting some tests, and then what we do is we come up with a plan to do some additional tests and to come up with a treatment modality for it. The progress notes, I know each of you do progress notes in your own practices. I want to point out a couple of things. This is basically, we use the SOAP method. Some people don't like the SOAP method, but this is pretty much the standard. But one of the things which can show up on your exam, so make sure you make a note here, is with the SOAP method, these are subjective observations of symptoms that are verbally communicated, okay? Things that are subjective is nausea, pain, dizziness, things like that, okay? We can't measure nausea. We can ask somebody to tell us how nauseous you are on a scale of 1 to 5, but usually people say I'm nauseous, or I'm very nauseous, or extremely nauseous. And pain is the same thing. We talked about there's a 1 to 5 scale, a 1 to 10 scale. Dizziness, that's a subjective symptom. My back is hurting is a subjective symptom. The objective ones, these are the ones that can actually be seen, heard, touched, felt, or smelled. Temperature, pulse, respiration, heart rate, blood pressure. And again, the aspect of it is that the objective, some people like to put more emphasis on the objective data because it is more concrete, for want of a better term. But this objective data is just a piece of the puzzle. The subjective may be just as important, okay? Your assessment obviously is the diagnosis. This is what you think it is. And then your plan is, what are you going to do? What test are you going to order? What treatment are you going to start? What type of follow-up? How often are you going to have them return to the clinic? Those type of things. So again, you guys, tenderness would be a subjective symptom because we don't know exactly how to measure tenderness. Tenderness is sort of like dizziness. You know that it's tender. You know that it hurts. The dizziness, here's one, like, for example, paresthesia. My arm is tingling. How do you measure your arm is tingling? So those are things that are very difficult to, basically we take it from the patient's perception. And one thing you might see with subjective is different patients may have different descriptions for really sometimes the same conditions. For example, paresthesias, like when you hit your elbow, some patients describe it as a tingling. Some people describe it as a numbness. Some people describe it as a burning. So again, different effects that are there. So your SOAP note, and I'm having to grade SOAP notes from my pharmacy students right now, is, one of the things we see is that sometimes they put things in the wrong area, but things that you should include is the date of the visit, the purpose of the visit, what were the patient's symptoms and complaints, you're going to include the current physical exam. Were there any new lab data or results of studies or reports or assessments that have come in, especially if you've seen the patient before? and formulation for the plan for the patient. One of the things that we're going to do is we're going to try to determine whether that patient, we need to have the patient come back. Whether we need to change our current thing. Maybe we've got some tests back that now suggest something else is going on. So that's going to be what we'll look for. Now, some of you will look at hospital records. Some of you probably may not see hospital records a lot, but hospital records, as I've mentioned to you earlier, can be a big mess. Theoretically, we should have most of the type of things we went over. So we should see the history and physical. I often want to see the triage notes if they've come into the ER. Follow the physician's orders, and many times you may have to be looking at, you have the hospitalist, and you may have another physician that may be involved. But really the physician's orders, this is the attending's orders, and it should be the directives, so you can look to see, or should be able to follow what the attending physician is doing. That's going to be accompanied by the nurse's notes. And that's going to also be, you're going to have the physician's progress notes. These notes in their entirety should basically chronicle the care of the patient throughout their stay at the hospital. And sometimes the way they're arranged in the records, it's very difficult to follow. It's jumbled. It's not like you would anticipate. What I've seen sometimes is I've seen them sometimes where they're in chronological order, which means that all of them are day by day. So I see the physician's notes, the nurse's notes, and everything else that happened that day. Other times I see the physician notes, and then I have to go to the nurse's notes section, then I have to go somewhere else. So that can be problematic. The consultation report, those come in. Sometimes those may be important. You're dealing with somebody with a mental disorder. One consultation you may want to see is if they've done anything like MRIs or any special scans, or if a neurologist has been consulted, or maybe a cardiovascular guy because of potential stroke or a heart attack. If they've had an operation, the operative report's pretty much got everything. If you read through them, I don't know if you've ever read one, it tells you even what size blade scalpel they used, what suture they used, where the incision was made, how the incision was, how the patient did during the surgery. It has the anesthesiologist information there. Sometimes if you're dealing with a patient that may have had a reaction or an issue that occurred during surgery, you may want to look at that. Throw out a different question here. When is informed consent required? I don't know how many of you have had to deal with informed consent, but so the issue becomes is that informed consent should be done before any procedure is done on issues that conformed consent is required. There are people that are arguing, that have argued that if you're using a drug off-label, that informed consent should be required. So the patient should know that you are using it off-label. But the bottom line is, if you are using a procedure, I mean, for example, you're going to do a surgery or something like that, then the informed consent needs to be signed before. I'm on the IRB here at the University of Georgia, and we constantly are sending things back and saying that the informed consent, these are at the beginnings before the studies have started, but we send them back saying that the patient or the exclusion criteria needs to be more explicit. And so, but the informed consent is not to be done, before they leave the hospital. It's pretty much supposed to be, if they're having procedures done, informed consent should be occurring before any of those procedures are. There are people sometimes that there are conditions where informed consent is not technically required, but we do see instances where I've seen clinicians that will sometimes, almost everything they do, they want informed consent. And the hospital record, this gives us the anesthesiologist report. One thing you might be interested there is you may want to take a look at the drugs or doses of the anesthetic drugs that are given. That could sometimes play into part. But getting to the answer to the question is informed consent, you are correct that it should occur before the procedure is done at the very beginning. And that is anytime there is some degree of reasonable risk to the patient, For example, you're not going to sign an informed consent every time you need an injection. But if I was going to be injecting intraarterial, then there's going to be an informed consent. And that informed consent is really designed to advise the patient of the risk and the benefits of the treatment and also of alternatives. So what else can we do, or what would be the alternative thing? And typically in describing this, we are telling the patient the alternatives are this, however, this is the best record for it, or this is the best procedure. We may have some diagnostic tests, pathology reports that come in. These are considered ancillary reports. They may be there. Some of the diagnostic tests, some of the pathologies you may be interested in, just depending on, sometimes they may do some additional biopsies or whatever. Sometimes when I'm looking through medical records, I may not think I want them, so I glance at them quickly to see if there's anything that may be something. So, Kirsten, you will, for any type of surgical procedure, there's going to be typically informed consent. Any type of invasive type procedure, typically there's going to be to do that. Now, there's the discharge summary that's another thing that I find very helpful sometimes, is pretty much it summarizes what's happened during the patient's hospital care, tells when they were admitted, what the diagnosis was, the general treatment, and it also tells the date of discharge. So one of the things is that can give me a lot of information with the patient's final diagnosis, and even, what the, particularly I'm interested in many times is the final diagnosis and the discharge meds. Now, they use DC, D/C or DC. The question is whether there's a lot of people that have specifically stated do not use those abbreviations because it's confusion as to whether it is discharge or discontinue. So where the confusion could be is during the discharge, they may put DC medications or DC and list a bunch of medications. So the question is, does that mean discontinue those medications, or is that discharge medications? In other words, the medications that the patient is being discharged with to be on. So sometimes what can happen is somebody can give a DC, and what they thought it was discharged from the hospital, and the person was meaning for them to discontinue the medications. And the reason they may want to discontinue medication is because they may have started a different medication. So I have seen the discharge medications and the discontinue medications, but the patient basically has been confused, or the caregiver, and so where they wanted them to discontinue ones and they were going to discharge them on something else, the patient is now taking 2 meds. So why should DC not be used? So basically, very ambiguous, and the confusion between whether it's a discharge or discontinue. Now, very quickly, let's talk about some common tests. We talked about these last time we met. So one test that we see that's a very common one is a complete blood count. So complete blood count, CBC, what they're going to do is they're going to pull a blood sample. They're going to give you, basically, they're going to tell you how many red blood cells they have. They're going to tell you how many white blood cells, and they'll actually differentiate as to the different white blood cells. And they're going to also tell you your platelet count. So if we suspect anything going on with the blood system, the hematological system, the complete blood count is going to be the test that we want. A urinalysis may be done, and that would give us the information about the kidneys. So urinalysis may tell us if there's protein in the urine, if there's blood in the urine, if there's white blood cells in the urine, if there is bile pigments, cast, and things like that. And then the metabolic panel, I think most of you will see it listed as a metabolic panel. These are the ones where typically you're going to get BUN, creatinine, AST, and ALT. So you get 2 liver, 2 kidney, and sometimes with the metabolic panel, they will also include thyroid. Sometimes you have to add that. And then the other thing they may have is a lipid panel, which would give you the cholesterol and the LDL and the HDL. These metabolic panels at different places typically they're going to be those 4 tests, liver and kidney, and a lot of people order a metabolic panel and a CBC, but you may see a metabolic panel and you may have to add on the other things that you wanted testing. Now, I wanted to also just briefly cover some of the imaging that we see that is commonly requested, and then we'll talk about a few abbreviations, and that will be good. And then I will allow y'all to take y'all's post-test. So, Marissa, one of the things you might want to prepare is that, so maybe in about 15 minutes is have the post-test ready so that they can take it before they exit, and we won't have them take it after they finish the class. So, so radiography is simple X-ray. It is a very, very, very archaic type imaging compared to what we do now, but the X-rays can give us some very good information. We still use it as a standard for diagnosing tuberculosis, and basically you're using ionizing radiation to pretty much to make an image on a film. But the problem with X-ray is its dimension is very limited. So we've gone to more gone to different imaging, which allows us a greater depth, and we can see things, 3-dimensionally. Also, we can see serial cuts, and we can see sometimes functional. So computed tomography, which is a CT, or computed axial tomography, which is a CAT scan, pretty much takes taking a series of cross-sectional X-ray films in a full circle rotation. And then what happens is the computer actually is going to convert, it takes the rates of absorption and density of these X-rays and makes it into a 3D picture on the screen. So it gives us much more detail than an X-ray does. It gives us depth, and it gives us more of a 3-dimensional component, and that makes it much more useful in finding things. Plus, basically here's the CAT scan, and you can see cross-sectional views, which they refer to as slices or tomograms, and that gives us 3-dimensional images. So it gives us a better perspective of, for example, tumors or various lesions. Now you can see the CAT scan standing there, and one of the big concepts is, I don't know if any of you have had it, but the biggest thing is a lot of people are very claustrophobic, and you have to, we do have ones that are open. They are not quite as sensitive as the ones that are closed. So now the question, to assess potential anemia, the potential of anemia, which of the following information would provide the most useful information? A CAT scan, MRI, CBC, or X-ray? And the correct answer is a CBC. Although we might be able to get some information from an X-ray. For example, if we looked at the bone and saw there was a very poor bone density or very bone marrow, that would suggest it. But the CBC would actually tell us whether the blood cells were there. Another frequent testing thing that we use is an MRI. This is a magnetic field, and what the magnetic field, what happens is you got these large magnets, and they generate a magnetic field, and then radio waves actually are transmitted, and they interact with actually the water molecules that's in the patient's tissues. So what happens is these radio waves going through this magnetic field basically cause a resonance, and that is picked up and is converted to an image. The nice thing about an MRI is it can give us information about structure and function. So an X-ray can't. An X-ray just says, here's the image, and we can tell if it's broken, we can tell if it's enlarged, we may tell if it's calcified, but we don't, and we can get the general shape of that. But the MRIs and the CAT scans give us much more detailed information. And now we're getting in some really interesting things like SPECT scans and PET scans. Here's the nice thing about this. So what we use in a PET scan is we use a radioactive isotope. What they use is a form of glucose. It's 2-deoxyglucose. So when the 2-deoxyglucose goes in, it's actually taken up by the brain tissue or by the organ. And so as the radioisotope sort of breaks down and decays, it emits these positrons that are picked up by a scanner. So what's nice about this is basically you can take images during a control period, and then you can do a task or an intervention, so you can get before and after pictures. So for example, what we have here on the slide is you have a normal elderly control, and you see brain activity there. And then in an Alzheimer's patient, you can see that there's been altered brain activity. So that's nice about these PET scans. And then we can get these SPECT scans. They give us a single static view. They're not quite as sensitive as a PET scan. They use a smaller amount of radioactivity, which is one of their advantages. We also can do some organ imaging. So we inject, either inject or have them ingest a radioactive isotope, and it emits gamma radiation. And that one will give us information about size, shape, sometimes the location, the function of the organs. We see those type. We see a lot of that used in the brain and the heart, for example. And I already talked to you about an MRI, so I have a duplicate slide here. The big thing about the MRI, which is new, is that the MRI, whereas the X-ray tends to be more limited to the hard tissues, the MRI is useful for soft tissues, the brain, the spinal cord, joints, and so forth. We can also do blood flow to look at blood flow in the brain or the heart or sometimes other organs. And then we can do diagnostic ultrasounds. These have actually become pretty, I mean, you can actually, there's programs that can go to an iPhone, which you can hook up a probe to. And what happens is like sonar. Pretty much what's going to happen is it sends down sound waves. These are reflected off structures and give us an image. Probably the best thing you see with that is women that are pregnant that are getting ultrasounds. So it can produce moving images, whereas an X-ray can't. So checking out the abdomen, the reproductive organs, the thyroid, parathyroid, these are the cardiovascular system, because we can do sonograms from those. And then the last couple of slides, I want to point out to you some important abbreviations that are error. The first two I'm not too worried about. These deal with right ear, left ear, or both ears, and deals with the eye. They can be confused. So when we're talking about if it's AD, AS, AU, it's referring to the ear. Think of aural. And if it's OD, OS, or OU, it's optic. So we have seen some confusions, especially with eye drops. If you put eye drops in your ear, that's not a problem. If you put eardrops in your eyes, that can create a problem. The ones that I want you to be aware of are the ones I've got identified in red. And one is QD. With QD, basically, that is an abbreviation for every day. So we may have a prescription, and we still see this one used quite a bit. So once a day, we may just put 5 milligrams QD. That means take it every day, once a day. You're going to be careful, because sometimes it may be, the way it's written out is it may come out as a QID. So some people's handwritings, it may come out as QID, which means that somebody's supposed to be taking it once a day. Now they're taking it 4 times a day. So they tell us to never use it, but I'm going to tell you it's still used quite frequently. DC and DC, we've basically talked about. HS means take at bedtime, but sometimes it's mistaken for as half strength. So the big thing that you would get with this would be primarily subtherapeutic dose. You wouldn't be getting as much. Here's a term that is abbreviation SOB. Does that refer to pupils, respiration, pulse, or blood pressure? Okay, most of you got it. This stands for shortness of breath, so it referred to respiration. And we've got these other abbreviations that I want to make sure you guys know. QOD is every other day. Sometimes that's mistaken using handwriting. Sometimes it comes across as QD. If you take it, supposed to take it every other day, and you're taking it every day, we can get, overdose. SC, SQ, and sub-Q can be sometimes confused between subcutaneous or sublingual. So we tell people to spell that out. That's not going to be one that you're going to run into very much. We do like on all of the records, date and time. When you're looking at records, it's sometimes easy where the way the medical records are is you're looking at the date of record, you may be looking at the date of birth date. So make sure you're looking at that. And it's preferable to use military time because that is the less error prone. So if I put down medication given at 1, and depending, I would have to look back to determine was it 1 a.m. or 1 p.m. Whereas if I put down, the right military time, then I know when that's given. The actual medical record abbreviations, these are where the JCAHO basically requires medical facilities to have a list of the authorized abbreviations. And not only does it have a list of the ones that can be used, but the ones that can't be used. And that was designed to really try to prevent errors that could occur due to poor writing or misinterpretations. So some of these are pretty straightforward, and we're going to go through the ones that, except for the ones that I've got in red. These are the different medical care facilities. Sometimes we see under ER, we see sometimes ED for emergency department. So we may see that. The medical care facilities, those are pretty straightforward, but we may see RTC or RTO, which means return to clinic, return to office. A lot of times that will be put in when you want the patient to come back. CP, chest pain. Sometimes for alcohol, instead of writing alcohol, they'll put ETOH, that stands for ethyl alcohol. But here's the ones that I want you to know is RRR, regular rate and rhythm. That could be referring to heart. It could be referring to respiration. SOB is shortness of breath. TR is treatment. Sometimes they may have TX, which is also an abbreviation for treatment. VS for vital signs. Temperature, pulse, respiration, blood pressure, height and weight. You all seen those. This is an interesting one here, WDWN. That basically, instead of saying somebody's fat, we use WDWN, which means well-developed and well-nourished. So it's one of ours. It's a politically correct abbreviation there. Y/O or YO is year old, getting to age. The number sign, if it's before the number, that means the number. So like number 3. If it's after the number, it refers to pounds. So sometimes you might see, so if it's number 3, for example, that would be a number 3 scalpel blade or something like that. But if it's 3 number sign, then it's going to be pounds. 3 hashtag. We do have the apothecary system, which we use. It's in pharmacy, and we see it used in hospitals. It's a method of liquid and weight measure. The liquid measure was basically, the liquid measure is based upon 1 drop. The weight measure was actually based upon a grain of wheat. Let's think about that. If you look at some of the common ones you see, fluid ounce you're aware of. GR is a grain. Some medications like morphine may be administered as a grain. GT stands for drop. The GT actually stands for gutta, which is Latin for drop. And then GTT is plural. And of course, a dram, an ounce, pound, or quart, those are all very common abbreviations. So I told you guys I was going to have y'all finished about 30 minutes ahead of time. The why not metric, we do see some more metric moving in, but this has been old Latin and they've stuck with it. Pharmacy, we still talk about apothecary, but things we see the apothecary still hanging on, and we do see more metric moving into. It's probably just being stubborn with trying to keep the profession sort of unique or whatever, but we do see that. All right. So we have completed the material, and so what I would like for you to do over this next week or so is practice with those blood pressures, pulses, respiration. Get comfortable with it, because I think Allison is going to have y'all work more on some of those when she meets with you on the next Saturday you meet. Like I said, I will be back with you guys on Sunday, and we'll finish up the class. On the Sunday, we finish class. There will be a assignment that I'll send out this week. I'll try to have the test up starting on Wednesday. I think Zoom will allow us to get the materials to you easier. And I appreciate you guys hanging in there. I appreciate you guys being receptive to Zoom, and it seems to have worked pretty well. So Marissa, I'm going to stop the lecture here, and if you will let them take the post-test, and then they can take the post-test and enjoy the rest of the afternoon. Yeah, there'll be just like we've done before, there'll be an assignment that'll put up on Wednesday or Thursday, and we'll go from there. And Joy, check with Marissa on that, and I think she can accommodate that. Marissa, you have any other questions? You have anything we need to do?
No, I don't think so. We're working on getting an Alliance account for the lectures.
Okay.
So just post them up on there. I made a channel on YouTube, but I'm not extremely tech savvy with YouTube, so I'm still trying to figure out how to get them to upload. The last time that I tried with the morning session, it said it was too big.
Okay.
So I'm going to play around with it a little bit and see. And if I get it working, I can email everybody out the link to that to get these up there.
That sounds good. Well, Marissa, thank you very much for a great job like you've done all along. And you guys have a great week, and I will see you in a couple of weeks. If you have any questions, just email me. All right. Good night, Marissa. Thank you.
Good night. Thank you.